again, I'm Estey, one of the Peds Emerge Fellows. Thank you for joining me today. So we're going to be talking about pills that can kill, and this was a topic that was actually requested by you guys. So certainly feel free if you have any questions to pass those along, and we're more than happy to answer those as we go. So what are we going to try to get out of today? So we're going to talk about the theory behind the one pill can kill. We'll recognize the 11 classes of medications which can kill a toddler with 1 or 2 standard doses, and we'll understand the typical presentations, initial stabilization, and treatment of these types of ingestions. So a little bit of background. So as we all know, and as I'm sure you've experienced, toxic drug exposure in toddlers is high. And this remains high despite the use of childproof containers, educational programs for parents and caregivers, and the increased use of regional poison centers. So looking at some data from the American Association of Poison Control Centers, also known as AAPCC. So this data is a little old, comes from 2000, but certainly we could probably speculate that the numbers have only increased from there. So in 2000, the AAPCC had over 1 million cases of potential drug exposures in children less than the age of 6. And this age group accounted for just over 50% of all of their exposures. If we look at the even younger age group, so kids less than 2, this accounted for 40% of all their exposures. And despite the fact that they had over 1 million cases, within this age group, thankfully, they only had 16 fatalities. So where did the idea of pills that can kill come from? So it started off in 1993 with the concept of 10 pills that can kill, and this number 10 has been attached to this for quite some time, but we'll talk about why things have changed in a little bit. So things started off with 10 pills that can kill. It was an initial study that was done by Gideon Corin, who actually works out of Sick Kids. And he published a paper on medications which can kill a toddler with 1 tablet or teaspoon. And so what they did was they looked at adult medications and figured out dose per weight that could kill a 10 kilogram or an average size 1 to 2 year old by taking 1 to 2 standard doses. And when they did this, they identified 10 medicinal preparations that had the potential to be lethal for a toddler in these doses. And then when they looked through the AAPCC databases, they found that these 10 preparations that they identified accounted for 40% of the fatalities in children under the age of 2. So certainly there was good correlation between theoretically what they had found and what was actually happening out there in the real world. So where did we go from there? So certainly between 1993 and when the update was done in 2004, and probably the same could be said for what's happening now, is the pharmaceutical industry has expanded. There's new drugs, new medications. And so in 2004, another physician who was working with Dr. Corin at Sick Kids thought they'd do an update to this. So again, look through all the new medications, trying to figure out which one in a standard adult dose could be fatal to a 10 kilogram toddler if they took 1 or 2 standard doses. And so when they did this, they identified not the 10 pills from the previous year's work, but 11 groups of medications. And when they looked at these 11 groups of medications, they accounted for 45% of the AAPCC fatalities in children less than 2 years of age. And interestingly, if you excluded iron, which accounts for quite a bit of mortality and ingestions in kids, but you need to take a much bigger dose. So if you exclude iron from that list, the 11 groups that we're going to talk about today accounted for 72% of the fatalities in children less than the age of 2. So toddler ingestions, how do these happen? What do you normally see? So oftentimes this is unwitnessed, and so what you end up with is a suspected ingestion, or what the toxicologists call an exposure. So there's no way to confirm that an ingestion actually took place, so they end up terming everything to be an exposure. So how do you find these kids? They might be found playing with pills or pills in their mouth. You might find empty bottles of medication. Parents or caregivers might note that there's missing medications, or most commonly they have unexplained signs or symptoms. And so you need to start wondering about what they could have potentially gotten into. So what types of symptoms do they have? Probably most commonly, they're asymptomatic, and you really have to worry then because you don't have any good clues. but they can also have altered level of consciousness, they seize, they can have vomiting, respiratory depression, arrhythmias. You can see the classical toxidromes. So we'll get into a few of these with some of the specific medications, but things like your cholinergic, anticholinergic, opioid syndromes, and then they can also just present with cardiorespiratory arrest. So consideration for you guys. So certainly you're the first responders and the first people on scene. So as you always do, have a look around. Are there any medications that are visible, any empty containers that are present on scene? Ask about what medications are present in the home. Consider possible exposures to the child. Have they been out of sight for a little while? Were they near the bathroom? Are things locked up? And then probably most importantly, are they in their home environment or are they in a foreign environment? Most families are pretty good about keeping things locked up at home, but what happens is when you visit another person's home, or characteristically grandparents who have medications, may not have childproof containers because they find them difficult to open, and certainly don't have the same extent of baby proofing that people with young infants and toddlers at home do. So what we're going to go through these 11 classes of medications. We'll talk about each one, the typical names for them, what it's used for, what symptoms patients who ingest them present with, and then what we can do about it. So we'll start off with the TCAs, so the Tri-Cyclic antidepressants. So these are things like amitriptyline, imipramine, desipramine, and there's a few more, but these three are probably the most common. And they were initially used for depression and anxiety, but as the SSRIs have become more popular and have a better safety profile, they've been used less and less for that, and have begun to be used more for a variety of complaints. So they're now being used in things like ADHD, migraine disorders, eating disorders, bipolar disorder. People take them for insomnia, irritable bowel, some of the neuralgias, and in pediatrics they're often prescribed for nocturnal enuresis. Thankfully, in some of these other cases, they're prescribed at much lower doses, but the potential for toxic ingestion, 1 or 2 pills, is still there with a little child. So signs and symptoms of a TCA ingestion. So primarily they get CNS depression, which can lead to seizures. Also can have dysrhythmias and classic cardiac conduction abnormalities. So the thing we always are taught to look for is the QRS prolongation. They can get hypotensive, and then they have that anticholinergic toxidrome. So they end up with the big dilated pupils, flushing, dry mucous membranes, tachycardia, hyperthermia, delirium, hallucinations. So the classic one that you hear of, red as a beet, mad as a hatter, I can't remember the rest of it.
Dry as a bone.
Dry as a bone, there we go. That'll go along with your anticholinergic toxidrome. And typically these types of symptoms are presenting within 6 hours of the ingestion. So what do we do for initial stabilization and management? So to start off from the EMS perspective, make sure these patients are on a cardiac monitor. That's going to be really important, especially if they do go on to develop an arrhythmia. You'll know about it right away. And then the other thing you have to anticipate is that they could have a rapid deterioration in their mental status or an abrupt onset of seizures. So certainly be paying attention and looking for those things, and have some benzos ready to go, because that would be your treatment of choice for any seizures. The antidote, I guess you could call it, for tricyclic overdose is an infusion of sodium bicarb, and we typically start that off at 1 to 2 milliequivalents per kilo given IV. And then the rest of it is just aggressive supportive care, so making sure they've got good access for fluids, airway management, and then they need to be observed for a minimum of 6 hours, and certainly longer if they start to develop any symptoms. So the next class of medications that we'll talk about is the antipsychotics, so things like loxapine, thioridazine, chlorpromazine. And these are used in cases like schizophrenia, psychosis, bipolar disorder, aggression, porphyria. And what do you see with these ingestions? So again, they have CNS depression, seizures, the anticholinergic toxidrome. They can get hypotensive, tachycardic. On your ECG, you see QRS widening and QTC prolongation. For initial stabilization and management, again, these are patients who you want to have continuous cardiac monitoring on, good IV access, and then again, it's mainly supportive care. So things that we look at once they get into hospital is whether or not we can do GI decontamination, and then looking at sodium bicarbonate infusions as well as our period of observation. And we certainly want a minimum of 6 hours and then 24 hours if you see any ECG changes. So the next group of medications that we'll talk about are the antimalarials. So things like chloroquine, hydroxychloroquine, and quinine. So these are mainly used for the treatment and prevention of malaria. So people who are traveling to malaria endemic areas, which can be quite common and includes a lot of the Caribbean and parts of Mexico. So even, you know, the holiday travelers might have things like these laying around their medicine cabinet, especially some of these medications you have to take for 6 weeks after you get back, and people kind of forget about it, and so the pills end up laying around. But they are also used to treat some autoimmune disorders, lupus, rheumatoid arthritis, and then in the past, quinine was also a common ingredient in some of the over-the-counter leg pain, leg cramp, restless leg remedies. These have since been pulled from the market, but certainly there could be people who have stockpiles in their home or older medications at home that could contain significant amounts of quinine. So signs and symptoms of antimalarial ingestions. So they get CNS alterations such as delirium, they can go into comas, they can have seizures, they get myocardial depression, they're prone to dysrhythmias, and they can also get hypotension and hypoglycemia. In the less severe cases, they can often start off with just some visual disturbance. So they might complain of things like blurred vision, double vision, altered color perception, tunnel vision, sensitivity to bright lights, as well as blindness. So your initial stabilization and management for this class of medications, again, includes cardiac monitoring. You don't want to miss those dysrhythmias. Making sure that you've got good IV access and you're able to give fluid boluses if the patient becomes hypotensive. Your good supportive care that you always give, consider glucose if they're hypoglycemic, and then sodium bicarb can be given as an infusion for these ingestions as well. So chloroquine can be a particularly nasty one out of this group, and there are physician protocols for severe chloroquine toxicity that talk about using high-dose epinephrine and diazepam infusions, as well as intubating and doing gastric lavage. So that might be something that would happen once you've transported into hospital. The next class of medications that we'll talk about is the anti-arrhythmics. So groups such as quinidine, disopyramide, procainamide, flecainide. Now this group is all class 1 anti-arrhythmics, and those seems to be the one that have the highest toxic potential in their standard doses. And what are these used for? Well, they're used to suppress abnormal cardiac rhythms. So patients who have AFib, aflutter, VTAC, and VFib quite often get put on class 1 antiarrhythmics. The toddler gets into them, the signs and symptoms that they display, primarily hypotension, but they also get QRS widening and QT prolongation. They can get varying degrees of heart block, also can get hyperthermia, hypoglycemia, and they can go into dysrhythmias as well, particularly VFib, VTAC, and torsades. So stabilization, again, making sure you've got that patient on continuous cardiac monitoring. If they're hypotensive, making sure that you've got good IV access and giving them a fluid bolus, good supportive care, and you can consider bicarb for this group of medications as well. Next group we'll talk about is the calcium channel blockers, so things like nifedipine, verapamil, diltiazem. These are used to treat hypertension, angina, some of the cardiac arrhythmias, and also can be used as migraine prophylaxis. So signs and symptoms of their ingestion. Patients can get hypotensive, get bradycardic, although in some cases, especially in pediatrics, they might have reflexive tachycardia instead of the characteristic bradycardia. They get hyperglycemic. You can see second and third degree heart blocks, and certainly these are patients who can easily go into cardiogenic shock and arrest. Symptoms tend to appear 1 to 5 hours post-ingestion of the immediate release preparations, but a number of people are on sustained release preparations of these medications, and those may not have symptoms for up to 14 hours. So initial stabilization and management of these guys, again, making sure you've got your cardiac monitor on, that you've got IV access. They can get quite profoundly bradycardic, so access to cardiac pacing is important. Fluids for their hypotension. They often do need inotropic support. Fluids won't be enough to correct this hypotension. And then things that we do in the hospital, looking at things like atropine and calcium, as well as GI decontamination with activated charcoal and whole valley irrigation. These are people that we monitor for an extended period of time, so the short-acting medications at least 6 to 8 hours and at least a minimum of 24 hours for the sustained release medications. So then we get into camphor. So camphor was a classic toxin that people used to spend a lot of time talking about. Not quite as common anymore, but we'll talk about some of the places it's still present. So camphor is usually found in ointments and gels, and it's present in some of the analgesic, anti-itch cooling gels, and also products that are designed to provide congestion and cough relief. So commonly things like Vicks Vapor Rub and Tiger Balm. Approximately 20 years ago, the government in both Canada and the US regulated the amount of camphor that can go into products to a maximum of 11%. Previous to that, there were things that had much higher concentration of camphor in it. And the original Tiger Balm that was on the market, and certainly that you can still get in some other countries, contains 25% camphor. So although it's present in smaller quantities and things that are locally available, you might consider that people might have picked up something from other countries that could have higher concentrations of camphor. And in other countries, there's a lot of homeopathic ointments and even suppositories that contain camphor that can get small children into trouble. So signs and symptoms of ingestion of camphor. They have that typical odor that if you've ever smelled Tiger Balm, or you can get the hint from Vicks Vapor Rub as well. They usually get into GI distress, so abdominal pains, vomiting, diarrhea. They have a generalized sensation of warmth, and typically you expect your onset of symptoms to be fairly rapid, so within 10 to 20 minutes of the exposure to the camphor. Initially they get CNS hyperactivity, so things like excitement, restlessness, progressing to delirium and seizures, and then after that phase is passed, they get into CNS depression, with coma being most marked, and then respiratory depression as well. And the deaths from camphor exposure and ingestion tend to be from respiratory depression and status epilepticus. So your initial stabilization and management, certainly there's no specific antidote. If somebody is covered in a camphor ointment, certainly you'd want to make sure that you remove as much of that from the patient as possible, and then it's going to be supportive therapy. So if they begin to seize, benzos are going to be your go-to agent in that case, and you're going to want to make sure that you've got good control over that airway in likelihood of decreased LOC, seizure, as well as respiratory depression. And even the asymptomatic patients in this class of medication should be observed for 6 to 8 hours. So the next group we'll talk about is methyl salicylate. So this is found in oil of wintergreen and has that very characteristic wintergreen smell, but is also used as in the deep heating and analgesic ointments. So things like Bengay and Icy Hot. And there have been some deaths within the last couple of years of young athletes who are kind of going overboard with Bengay and Icy Hot and continuing to use large amounts on a regular basis for muscle aches and pains. And there were a couple of high school athletes and a couple of university athletes who have died from methyl salicylate toxism in the last couple of years from overuse of these products. So if you think an adult-sized person using it can get into trouble, certainly a toddler using a much smaller amount can get into trouble as well. So 1 teaspoon of oil of wintergreen, which tends to be about 98% methyl salicylate, actually contains 7 grams of salicylate. So that's comparable to taking 90 baby aspirin. So even small amounts of this oil of wintergreen can get you into some big problems. So signs and symptoms of ingestion of these products. Similarly to the camphor, you're going to have that very characteristic smell. Patients get into GI distress with nausea and vomiting. They also get quite diaphoretic. And one of the earliest signs of salicylate toxism is that they get tinnitus or ringing in their ears. Probably not going to help you too much with a toddler who's not able to express and complain about that. But one of the earliest signs. And then you get some nonspecific neurological findings. So agitation, delirium, hallucinations, they can become lethargic. Initially you get respiratory stimulation, so they hyperventilate and breathe quite quickly. And then with severe intoxications you get pulmonary edema, cerebral edema, coma, hyperthermia, and eventually death. So initial stabilization and management. These patients need aggressive supportive care. Certainly if this is something that's found on their skin that needs to come off, you can consider gastric decontamination, sodium bicarb to try to reverse some of the acidosis that's happening. And then usually what ends up happening is with significant ingestions they need hemodialysis. The half-life of salicylates is generally about 2 to 4 hours when you're looking at therapeutic levels, but it can increase to 15 to 29 hours once you get into toxic dose ranges. So this is something that's not going to be cleared from the body quickly. So the next medication that we'll look at is Theophylline, also known as dimethylxanthine, used mainly for COPD and asthma. So signs and symptoms of Theophylline ingestion. So they have vomiting, they get anxious, get agitated, they can seize, they can also have ventricular dysrhythmias, hypotension, and tachycardia. Things that you're doing for these patients, again, as with the majority of these things, a lot of it comes down to just general good supportive care. They can get into dysrhythmia, so you'd want to make sure these patients are on a monitor, that you've got IV access and fluids. They might need inotropic support, seizure management, again, with your benzodiazepines. And then if they have profound vomiting, consider some of your antiemetics and GI decontamination if they've had a recent ingestion. The next group is something that you guys are all probably very familiar with to varying degrees over the course of your practices. So narcotics, so things that we're looking at are codeine, hydrocodone, methadone, morphine, and these are used in analgesia but also have a variety of sources of abuse as well and are found quite commonly in prescription and abuse forms within homes. So codeine, you have to remember, is also present in things like cough syrup, and there have been phases where codeine cough syrup has been widely abused and widely found in homes. It's got that characteristic purple color and is usually known as purple juice and purple stuff, and has various names that involve purple. And then methadone, certainly we see a ton of here in London as well. So as you know, for narcotic ingestions, they get the classic opioid toxidrome with CNS depression, respiratory depression, and the pinpoint pupils. And typically they start to exhibit symptoms within at least 1 hour of ingestion, oftentimes much sooner. So your initial stabilization and management, again, good supportive care, and then consideration of Narcan. The next group we'll talk about is the oral hypoglycemics, and particularly the bad ones tend to be the sulfonylureas, so chlorpromide, glibenclamide, and glipizide, and these are used mainly for type 2 diabetics and their treatment. So the main symptom you're concerned about with this group is hypoglycemia, and then the rest of this list of symptoms is secondary to that. So people who can get profoundly hypoglycemic get lethargic, they get confused, they can have headaches, they can be irritable, they can seize, and especially in the younger kids in pediatrics, if they have extended periods of hypoglycemia. They can have permanent neurological impairment, and then, of course, death. So your initial stabilization and management of these patients, you certainly want to keep a good eye on what their blood sugar is and make sure that you're doing serial glucose measurement, as well as neurological exams for some of the other findings of the things that we talked about. So within your protocols for your IV dextrose boluses, so they vary depending on the age of the patient, so we've got those broken down here. So infants less than 30 days of age, you're looking at D10 and giving a bolus of 0.2 grams per kilo or 2 cc's per kilo IV. Once a patient is greater than 30 days of age but less than 2 years of age, you're moving on to D25 and using a dose of 0.5 grams per kilo or, again, 2 mils per kilo. And then once they're over the age of 2, you can go on to use D50 at a dose of 0.5 grams per kilo or 1 ml per kilo. Now, the concern with the higher concentrations of dextrose in the little ones is twofold. One, it's quite hypertonic and it can be quite irritating to the littler veins, but also, as you know, those liquids are quite thick and can be difficult to push through a small IV. So that's why we tend to use things like D10 and D25 in smaller kids. So if your dextrose isn't working or you've run through your bolus protocol, you can use glucagon IM at doses of 0.5 milligrams for less than 25 kilos and 1 milligram for greater than 25 kilos. You have to be aware of rebound hypoglycemia after you give a bolus of sugar. So giving the big bolus of dextrose may exaggerate may stimulate exaggerated insulin release from the body. So you need to make sure that even after you've given your bolus and you've checked again, you've seen that that sugar's come up, that you're still keeping a close eye so that you don't end up in a situation of rebound hypoglycemia that goes unnoticed. Once they get to the hospital, we'll look at considering GI decontamination if their ingestion has been less than an hour or if they've taken in a sustained release preparation. And then these patients get watched for quite a long period of time. So usually we recommend a minimum of at least 24-hour observations, checking sugars probably every 30 minutes to an hour. So it's a rough 24 hours for these little guys with constant pokes. But unnoted hypoglycemia can be just catastrophic, so we keep a close eye on things. And the last medication that we're going to talk about today is Podophyllyn, and particularly the 25% concentration. So this is mainly used to treat genital warts and molluscum contagiosum. Genital warts is fairly self-explanatory. Molluscum maybe everybody hasn't heard of before. So molluscum is a quite common pediatric dermatological condition. It's caused by one of the human herpes viruses. I think it's either 6 or 7, but don't quote me on that one. And it can cause quite significant eruptions in younger children. Some people might get only 1 or 2, but some children can get hundreds of these little bumps, and what they look like is they're little kind of flesh-colored pearly papules, and they usually have central umbilication to them. So usually Podophyllyn is not a big concern unless you get into these cases where children are just covered in hundreds of them and somebody's been very aggressive about trying to treat them and ends up using a lot of Podophyllyn, not recognizing its toxicity. So normally the 25% concentration is just available to medical professionals, and the dermatologists are certainly very careful about making sure that they're only treating 5 to 10 lesions at once and not going overboard. But in other countries you can get higher concentrations of Podophyllyn over the counter, and somebody might potentially have this at home and either applying higher concentrations to their child, or a child accidentally gets into a family source. So signs and symptoms of Podophyllyn ingestion. So starting off with GI complications, they get nausea, vomiting, abdominal pain, and diarrhea. and then they get CNS depression, so they get quite confused, obtunded, they can go into a coma. They get delirious and they have auditory and visual hallucinations. They can also get paresthesias, cranial neuropathies, and absent deep tendon reflexes are characteristic of pedophyllin ingestions. Once they get to the hospital, if we do blood work on them, characteristically they can get a hematological toxicity, and you'll see pancytopenia on their CBCs. So stabilization and management of these guys, again, you're looking at good supportive care, removal of any topical applied solution that still might be on the patient. And then once they get to hospital, we'll consider GI decontamination and making sure that we observe these patients for a minimum of 12 hours and longer if there's a significant history of having a dermal exposure, because that can take longer to get absorbed through. So these are the references that you can look at for more information on any of these topics that we've covered, and at this point I'm happy to answer any questions that may have come up.
So Andrea, that was a great review of those medications. I mean, I think it's a key thing to remember from a pre-hospital perspective, especially, you know, kids often present asymptomatic or have, you know, they don't have the history of ingestion and we don't figure it out initially, but to think about some of the common presenting complaints that they have and could it possibly be an ingestion is great. And a lot of these things are in our house. We keep them there for, you know, the Vicks Vapor Rubs and the Benghaze are sitting there, and they certainly do have quite significant toxicity associated with it. Another point that I think that you made numerous times, and I think is really important to remember, is the asymptomatic child. And it can take a long time for them to actually develop their symptoms. And so, you know, if just because when they're not symptomatic on initial assessment, it can take 6-8 hours before they develop significant toxicity. And so we have to watch them in hospital for at least that long. So it's important, even when they're asymptomatic, that they probably still need to be seen in hospital and observed. So I think that was excellent.
Absolutely.
Good. So once again, a thank you to Dr. Estey and Dr. Peddle for a fantastic presentation. There was one question that came through on the chat box, and I'll just reiterate what that question was so that everyone has a chance to listen to it. The question is, what is actually involved in GI decontamination, and whether it's a case of simple activated charcoal, or is there something else involved in that process?
Yeah, so GI decontamination is an interesting topic and something that's very controversial, but the basics of it, the mainstay is activated charcoal. Certainly there are some medications, iron, lithium, that are not absorbed by activated charcoal, but the vast majority of medications are, so certainly you can consider activated charcoal. Anytime you're looking at GI decontamination, you always need to consider whether the patient can tolerate it and whether there's going to be a potential risk for aspiration. So activated charcoal could be very nasty if the patient then suddenly becomes unresponsive, starts to seize and vomits, and they aspirate it into their lungs. So you need to kind of think of what you're expecting to happen with the ingestion and prepare for it. And if it's a particularly nasty ingestion, like some of the calcium channel blockers where there's not a whole lot we can do about it, but we think maybe we could get some of the medication out with GI decontamination, then what we usually consider is taking control of the airway, intubating the patient, protecting that airway, and then moving on with our GI contamination. So certainly activated charcoal is one method. Other things that we look at are whole bowel irrigation. So that would be when you'd be sticking either an NG or an OG down and running something like Peglite or Go Lightly through at high volumes, hoping to just keep running it in at very large volumes until you see it start coming out clear at the other end. And I've certainly heard anecdotal stories from people who have decided to do whole bowel irrigation and run through massive amounts of fluid and seen pills pop out the other end. So it certainly has a role in some of these ingestions, especially the particularly nasty ones where you're worried there's nothing much else you could do and there is a real potential for a child to die.
One other question that's popped up here. Is there any concern with hypokalemia with what you just described?
Yeah, so absolutely there is. Anytime you're putting massive amounts of fluid through the GI tract, you need to be worried about electrolyte shifts. The things we try to use usually are electrolyte neutral, but definitely something that you'd want to keep a close eye on.
Great. So we do have the opportunity, if anyone would like to ask a question live. You have an icon that looks like a hand in your taskbar, and if you'd like to click on that hand, that shows me that your hand is up and you'd like to ask a question. So you do need to have a microphone in your computer if you'd like to do that. So I'll give some time to see if anyone would like to do that. I do have another question here. The question is, would it be possible to print a small booklet with pictures of the top 11 dangerous pills with, again, signs and symptoms and possible treatments? If you're able to maybe let us know, are you talking about maybe in your paramedic pocketbooks? If you actually have a microphone, it would be great to talk to you and see what exactly you're looking for. I'm not sure if you're just looking for...
Yeah, I can address that a little bit.
Okay.
So I actually, in my initial version of this presentation, had some pictures of the medications, but unfortunately we had to take those out for copyright issues. The biggest problem with getting pictures of these medications is that the majority of them are older medications. They've been around a really long time, and so they're generic. And so every company makes them, and every company's pills look a little bit different. So even when I was trying to find some pictures, thinking I would be allowed to use them for this presentation, there's a huge variety. Even if you try to look up Tri-Cyclics, I found hundreds of pictures of different looking Tri-Cyclics. So to try to just have a picture of 11 pills isn't going to be possible with this diverse range of products.
And I'm sure things will probably change 6 months down the road, a year down the road with a few drug companies. Are there any other questions out there? I don't see any hands up. I don't have any others typed in. I'll just give you guys an extra maybe 10-15 seconds to come up with some questions. Okay, well, it doesn't look like there are any additional questions. So again, thank you to Dr. Estey and to Dr. Peddle for a great presentation. Keep an eye out at your service emails to see when our next webinar is. And once again, thank you for joining us and have a great afternoon.
Thanks, everyone.
Thank you.